Okay, so here we are, our 1 o'clock hour. Hopefully everyone had a great lunch and you know they're happy and fed and ready to focus. Although I do find that sometimes after lunch it's not as easy. Just quick off the top, any announcements or changes or anything, Keith?
I was looking at the schedule, and if you're running short on time and want to devote some more time to cannabinoids and so on, next Tuesday, we could share that hour or something like that.
Okay.
So see how
Yeah.
it goes. And if you want to take a little more time, feel free to do so.
Okay, that'd be great. Yeah, I was looking, I was trying to figure out how to fit cannabinoids and, histamine into such a small chunk of time. So we'll just have to, I guess, see how we end up at the end of tomorrow.
Yeah, I don't want you to feel like you got to rush through the cannabinoids because that's an important topic. So
Yeah, and I feel like so relevant right now. It's something
it
that's,
is.
possibly going to change in the next month or so here in Montana. So
Yeah, we're coming up on an election, all right.
yeah.
Okay, that was my comment for now.
Okay, great. Any questions or concerns before we get started with material? I guess like usual, if you do have any comments as I'm presenting, I am keeping my eye on that chat. And so if you do have anything that kind of comes to mind as I'm going through it, just feel free to pop it up right there. I'll try to make sure to read your question out loud. If I don't, somebody in the class, feel free to also remind me, just to make sure that everybody kind of knows where the context of whatever question I'm answering. Um, so again, we've talked about dopamine. Now we're going to transition into serotonin. Again, this is something Dr. Parker knows a lot about. So any and all questions you have today, I'm probably going to need to defer to him if it doesn't hit my point of knowledge. But I think we're in for a treat. Okay, so the roadmap, again, for all of these neurotransmitters, I'm keeping it basically the same just because I think it's a nice consistency to compare and contrast them in these different ways, talking about the history of their discovery and then working our way up through kind of the levels of complexity, going over chemical structure, synthesis, and then synaptic and receptor properties, and then kind of finishing off talking about things like disease states and then some of the therapeutic approaches for that. Okay, so the history of serotonin. So it was first demonstrated by Erspringer in 1935 from enterochromaffin cells. So again, we're talking about something outside of the central nervous system that made muscles contract. So it was not adrenaline. So that was kind of one signaling system that they could essentially disregard. So, but of an unknown means, so they named it enteramine. Then kind of fast forward to 1948, Maurice Rapport, Arda Green, and Irving Page, I included a picture of Arda Green here, discovered a vasoconstrictor in serum and then thus naming it serotonin. So it really wasn't until 1952 that kind of the discrepancy between these two chemicals was kind of found. And so they again realized that that was the same chemical kind of demonstrating both of these properties and thus the same substance. And so they identified the substance as serotonin. So that's kind of just like the origin story. Again, they recognize it as a constrictor in serum, and so it was increasing tonicity. So thus serotonin being the nomenclature that was used to describe it. In terms of the overall structure of serotonin, it's 5-hydroxytryptamine, the chemical structure. So in this presentation, you'll see me kind of going between serotonin and 5-HT. So if you see 5-HT, I'm obviously referring to serotonin. It's a monoamine neurotransmitter, so it falls within that category. Just kind of an important side note is that many of the N and O methylated indolamines, such as N and dimethyltryptamine, are hallucinogenic. And so we're going to talk about some other hallucinogens that are able to target this particular signaling system, and maybe some of the historical reference of that as well. So this particular chemical they're referencing here, you can kind of see down here in this figure as well, and then also compare the structure to that of the 5-hydroxytryptamine or serotonin. Other kind of something else to note here is also the chemical structure relationship to melatonin. And we'll see how serotonin serves as a precursor to melatonin. So it's synthesis. So if we look at the synthesis of serotonin, you can see here that it's derived from L-tryptophan. It's actively transported to the brain by LAT1. It is a transporter for other amino acids, and so there is some competition for that particular transporter. Recognizing that the rate limiting steps is the TRIPS enzyme. It's responsible for the synthesis of 5-HT, but recognize it's not the enzymatic action that is a rate limiting step for the production of serotonin. It's actually the presence of the tryptophan that is the rate limiting step. And so generally you don't see saturating concentrations of that in the brain. And so that's going to be part of the rate limiting step for the synthesis or the generation of it. As we're kind of going through the other steps here, you can see that serotonin can be metabolized into melatonin. And it's important, as the textbook editor wrote, it's important not to confuse melanin with melatonin. Melanin is the pigmentation in your skin. And then if you look at the very bottom of the slide here, it's one of those sentences that you read a textbook and you're like, did they really mean to write that? And they actually refer to melatonin as the pigment of imagination. Again, due for its relationship in the brain, and we'll talk a little bit about how it plays an important role in sleep. So the primary role of metabolism for serotonin is through the MOA-A. So you can see that here. And the reduction to 5-hydroxytryptophan is fairly insignificant. So when we were talking the other day kind of about the distribution of the two enzymes and kind of if there's a preference to one or the other, and this is kind of a place in the textbook where they noted kind of a preference. And so your I guess the production that you see here is fairly insignificant. Majority of it is being metabolized into this 5-IIH or 5-hydroxyindoles acetic acid, and then that's going to be excreted through the urine. While we're talking about serotonin, again, you can see that it can be metabolized into these two products as well as broken down or synthesized into melatonin as well. Okay. Any questions or concerns at this point? Okay. Okay, so as we're looking, again, kind of keeping the same similar structure for all of the neurotransmitters that we've been talking about, we've talked about kind of the synapse and all of the different areas of the synapse in which regulation can take place, or there can be pharmacological intervention. So it's important as we look through that, we keep that in mind. Obviously, anywhere you see the red is going to be a place where an inhibitor or some type of pharmacological intervention can take place. So if we're looking at the serotonin synapse, you can see here you have your tryptophan that is converted into your 5-OH tryptophan, and then ADC generates the 5-HT or the serotonin that gets loaded into vesicles via VMAT2. We've seen this particular transporter in the past. We've also recognized that there is a pharmacological intervention or a blocker that can block the loading of the synaptic vesicles. And then once a depolarization has occurred, you've got fusion of the synaptic vesicle in the presynaptic compartment to cause release of serotonin into the synaptic cleft that you see here. What's interesting to note is that I always like to say, postsynaptic-ish signaling. It's basically signaling because I put the word ish in there because you have both presynaptic and postsynaptic receptors that are expressed in the serotonergic synapse. So here you can see a 5-HT1D that is expressed presynaptically. And then you can also see this series of postsynaptic serotonin receptors expressed here. This particular figure has a lot going on, but I think it's nice because it's a great synopsis of all of the signaling kind of cascades also that occur downstream of the different serotonin receptors. And then as obviously after serotonin is released into the synapse, there has to be some mechanism in which to terminate that signal. And so that occurs through the reuptake through the 5-HT serotonin reuptake inhibitor or reuptake the transporter SERT. And so here you can see the expression of SERT on presynaptic cells. Again, the red coloring here are going to be kind of an outline of all the antagonists or blockers for each part of this specific pathway, or targets for proteins or transporters. And then you can see here there are some like lighter, some black lines and words as well that are indicating partial agonists or for some of these just specific postsynaptic receptors. And so again, like I said, I feel like there's a lot going on this particular slide, but it's so informative in a lot of ways because when we're talking about pharmacology, I think it's so important to kind of think about the targets of each one of these drugs. And I think this particular slide does a really nice job of pulling in a lot of those different targets and some of the drugs that are targeting the mechanism of synaptic release and diffusion of the neurotransmitter across the synapse, as well as the binding to the postsynaptic receptor. And then the kind of that final step is the reuptake of the neurotransmitter. Do you need to know every inhibitor or pharmacological agent in red? That's, I mean, I want to, my knee-jerk reaction is probably, yes, it's worth noting. I think, especially anything that is affecting any of the receptors or transporters, I think we'll probably see those being used more frequently. It's going to be shown on this slide, and then if it's another drug that we see that we revisit later on when we're talking about therapies, it's definitely worth noting because you'll see the overlap of one where the mechanism of action is, and then also kind of how it's therapeutically applied. But just recognize we're kind of taking a turn to the course where we're going to be focusing a lot more on drugs and drug targets. So I hate to say that there's going to be some memorization, but I definitely think it's worth your time to start focusing on some of the drugs that we're mentioning in class. And I see Keith, so I'm going to pause here.
Just really to reinforce what you're saying and something for the students to think about in terms of not worrying too much about all the different names right now, is that there are segments of the course upcoming in the next month or so which are devoted to antidepressant drugs, to antipsychotic drugs, to anti-migraine drugs, for example. So you'll get to revisit this and reinforce those ideas as we go along. So maybe that'll make looking at all the different names a little bit less scary right now, knowing that we're going to be back into that a little bit later in the course too.
Yeah. Yeah, and I think it's nice that repetitive kind of nature where we get to see things from multiple perspective, you know, talking about it from the synaptic perspective and then again revisiting it as a therapeutic. So in terms of the receptors, you'll kind of see the laundry list here of multiple serotonergic receptors and receptor subtypes. And so again, it's quite the list that you can see here. And you'll see all recognize some of the signaling effects here will be grouped based upon their different coupling to different G proteins. What's also interesting to note is the localization of the different receptor subtypes and their expression across the brain. And then also, lastly, some of their functions. You'll recognize that some of the subtypes act as autoreceptors. They're going to be expressed on essentially that presynaptic side, and we'll look at an example of an autoreceptor here in a few slides. And then some of the subtypes are going to be seen not necessarily in the central nervous system, are expressed more in the peripheral system, not nervous system, but the peripheral system, such as the stomach fundus. But again, it's just kind of, I think, worth checking out some of these different subtypes, as well as recognizing their localization and then their different signaling effects. And the next slide that we look at, we're going to definitely be digging into some of the different characterizations of each one of the receptor subtypes. And then I guess kind of the last thing to note, which is really informative of this slide, are things like some of the agonists and antagonists. And you'll recognize that some of these agonists we'll be talking about multiple times when we're talking about therapeutic approaches. Something like sumatriptan is something that we'll be mentioning a little bit later, specifically in the treatment of migraines. Hi, Keith.
Yeah, just a note going back to the historical thing a little bit. And our emphasis these days when we think about serotonin is so much as a neurotransmitter, but the huge amounts that are found in the gut suggest even an almost hormonal action. It's often called autocoid, which is kind of intermediate between distance relationships, like you would find short-term neurotransmission, longer ones hormonal. So it's a mixed bag in terms of neurotransmitters and hormonal stuff. And really cool that and I'm sure Katie will be talking about this more, that the 5-HT3 receptors are not G protein coupled, but they're ion channels. And in fact, they're more like nicotinic receptors really than G protein coupled serotonin receptors. Okay, thank you.
Okay, so again, this is just kind of another iteration of the table, the table that we just saw, just kind of breaking down, I think, a more simplified version of these receptors and exactly how they're G protein coupled, since that table kind of omitted that information, but did talk some about some of the downstream signaling pathways that get activated. So 5-HT1, 5-HT2, so you can see the different subtypes 1 through 7 here. Again, this is a little bit more broad over characterization than what we saw in the previous slide. Like I mentioned before, the 5-HT1A and 5-HT1B-D or /G act as autoreceptors. And so you can see kind of an example of what that autoreceptor expression looks like here at the bottom of this slide. So that 5-HT1A, the dendritic projection actually projects back onto the soma. So when you see things like the somatic dendritic autoreceptors, that's the description of that projection and how it's signaling back onto the soma of that cell. And again, if we look at what the downstream effects of that are, obviously altering the synaptic, possibly altering the synaptic accumulation at the soma itself. And then if we look at the presynaptic autoreceptors, again, this is not somatic to dendritic. We're having it released into the synaptic cleft, and then it's essentially doing some retrograde signaling back onto the presynaptic compartment. And so this type of retrograde signaling that we're seeing here is something that we'll see when we talk about the cannabinoid system as well. Kind of, again, continuing down this laundry list of serotonin receptor subtypes, you can see that the 5-HT2 is G alpha Q 11 proteins are coupled and activate that phospholipase C pathway. And then 5-HT3, as Keith kind of just alluded to there, is interesting because it's the only monoamine neurotransmitter that functions as a Leukin-gated channel. So it's very unique in that respect. The 5-HT4 couples to GS and obviously is important to adenylate cyclase. 5-HT5, again, is inhibiting adenylate cyclase. So it's interesting to see kind of that push-pull of different receptor subtypes and the downstream effects that they have. And then 5-HT6 couples to GS and activates adenylate cyclase. And then 5-HT7 couples to GS and activates adenylate cyclase. So we see some overlapping pathways here, and some of them have specificity. Again, it's going to depend not only on G protein coupling, but also where the receptor is expressed in terms of its ultimate function in the central nervous system. So those two things are, I think, are always important to ask yourself when you're talking about different receptor types. What is it coupled to? What is the signaling? And then where is it distributed in the brain? And what's the function of that particular region? And so when we get to the slide talking about physiological functions, you'll kind of see how the different receptor subtypes are expressed in regions that have multiple functions. So as we're talking about kind of the different components of the synaptic signaling process. Again, an important target for pharmacological intervention is the serotonin transporter SERT. Similar to what we saw when we were talking about the dopamine transporter, it's a 12-membrane spanning domain transporter expressed in the raphe nucleus. We'll talk more about the distribution of serotonin and why that's important. And platelets, placenta, lung, gut, enteric nervous system, and adrenal gland. So again, not just solely in the central nervous system are you seeing this transporter, again, because the signaling is not necessarily dedicated to just that region. Similar to what we saw with the DAT is that it's coupled to sodium, again, using that sodium concentration gradient to essentially pull the serotonin into the cell. And in terms of pharmacological targets, you can see here, there's quite a variety of drugs that target this particular system. Fluoxetine, paroxetine, citalopram, sertraline, all are going to be your SSRIs or your selective serotonin reuptake inhibitors. I think these are probably a whole category of drugs that we could talk about extensively and kind of the history of their use, because I feel like they've been particularly, I guess, a huge life-changing types of drug class in the last 20 or 30 years for treatment of major depressive disorders, and we'll talk about that a little bit later on. SNRIs are also targeting the transporter. They're a little bit more non-selective because they're hitting both the SERT and the norepinephrine transporter. And so these are going to be prescribed for major depressive disorder, obsessive OCD, panic, generalized anxiety disorder, fibromyalgia, neuropathic pain. But again, we'll talk more, I think, about the targeting in these therapeutic approaches in a few more slides. So distribution in the body for serotonin, again, this is pretty interesting because we're not just talking specifically about the central nervous system. In the cardiovascular system, one of the main functions of serotonin is going to cause contraction and have other cardiovascular effects. In terms of its effect on platelets, it's taken up in fluid circulation and stored in secretory granules. And so 5-HT is going to be released in any type of damage type of situation. And so when we're talking about platelets and its release, this figure here is actually a great example of that. If you have vascular injury, you have this initiation of platelet aggregation and then ultimately the release of serotonin. And that's going to be hitting the 5-HT1-like receptors or the 5-HT2. And that's going to ultimately help in setting forth a series of signaling cascades that lead to things like vasoconstriction, thrombus, as well as vasodilation. And then kind of finally that last stage of this whole signaling cascade, which would be hemostasis or vascular occlusion. So it's going to be very important in essentially in healing and in the process of recovering from vascular injury. In terms of the gastrointestinal tract, again, if we look at kind of the history of serotonin, it was first characterized in these enterochromaffin cells in the gastric mucosa. And again, this is a huge site of synthesis and storage of serotonin. Large percentages is found in that area. And then in terms of the 5 of inflammation, there are a couple different receptor types that are actually pro-inflammatory. And so we'll see that expression in the peripheral blood of mononuclear cells, also in patients with history of asthma. So there is a role there definitely for inflammation, specifically in folks who are suffering from respiratory depression that is seen in asthma. And so, again, as we're talking about the role of serotonin in the gastrointestinal tract, this table here does a nice job of showing the different receptor subtypes and then the different types of cells that are located within the gastrointestinal tract. So it's not just the enterochromaffin cells. You're also seeing it on the enteric ganglion, the smooth muscle cells, as well in both the intestinal, stomach, and esophagus. So serotonin plays an important role. I guess we can't be overstated, not just in central nervous system function, but also in the process of the gastrointestinal tract, as well as in the immune system, as we're kind of seeing with this slide. So I guess it's kind of hopefully kind of eye-opening to think about serotonin and not just that way that we thought about. I think when people talk about serotonin, they tend to just solely focus on like their function in SSRIs, but there really is I think a more prolific kind of extension of serotonin into the rest of the body. And so I guess kind of the last slide was really focused on all those different regions of the body. But if we bring it back to the central nervous system, this particular image does a nice job of showing you kind of the projections of the serotonergic outputs into the brain. And so here you can see, again, the raphe nucleus is going to be kind of a cluster of nuclei that is going to extend these projections and release it to a multitude of regions in the brain. So we see it extending into the thalamus, the striatum, the frontal cortex, and then you could also see its important role in signaling in the cerebellum as well as the brainstem. In terms of some of the physiological functions of serotonin, we can see that there's a vast array of functions of this particular neurotransmitter. So it's, again, not just as we think of as the mood hormone, but it also affects things like sleep. Again, we could talk about its role as a precursor to melatonin, cognition, the sensory perception, motor activity, temperature regulation, nociception, mood, appetite, sexual behavior, and hormone secretion. This figure here also, again, kind of compares and contrasts some of the functions as well as the projections with the dopaminergic system. If we talk about the sleep-wake cycle, again, it plays an important role. There's specific receptor subtypes such as the 5-HT2AC that is important for inducing slow wave sleep. So that antagonist, that's riticerin, actually antagonizes this receptor and allows induction of slow wave sleep. And so, again, it's just another pharmacological intervention that we might not think of when we think about serotonin. In terms of aggression and impulsivity, again, when we talk about its role and projections into the brainstem, it's been shown that low CSF levels of this 5-IAH, again, the byproduct of serotonin, is correlated between violent impulsivity and aggression, and that there are knockout mice that exhibit extreme aggression. And then there are some human studies that have identified a point mutation in the enzyme responsible for breaking down serotonin that was associated with extreme aggressiveness and mental retardation. Lastly, another physiological function that you might not think of is one with appetite and obesity. There have been some drugs that have been utilized for weight loss purposes. One that's kind of, I guess, worth noting down here, phenylphoramine and dexphenylphoramine. You may have heard of the drug fen-phen that at one point was very popular on the market to promote the release of 5-HT and block its reuptake to reduce appetite. But due to some negative side effects is no longer on the market. Okay. So as we talk about serotonin and focus on some of the drugs that are important for altering serotonin signaling, again, some of these were drugs that we saw in that first slide when we were talking about synaptic signaling, drugs that act as either a partial agonist to the receptors themselves or antagonists or as inhibitor for reuptake. And so partial agonists like buspirone or isoprone are going to be used to treat things like anxiety, depression. Again, these are partial agonists. When we talk about the treatment of migraines, we're going to talk about cimetropin, which is an agonist for the 5-HT1D receptor subtype. And again, you can see a series of antagonists also, so that are also utilized for the treatment of things like migraine, depression, and schizophrenia. Again, it's worth recognizing down here the block of the transporter, the inhibitor of transport, fluoxetine and citrulline are very popular drugs that are utilized to treat things like depression, OCD, panic disorder, and social phobias, things like generalized anxiety disorder. I'm going to pause for a second. Does anybody have any questions or concerns as we're going through this material?
Just a little tie-in with some things from this morning. If you look at the list that you've got in front of you right now, you notice about in the middle of the slide that drug called methysergide. That's another ergot alkaloid. And if you remember back to some of the adverse effects from this morning, one of those mentioned was fibrosis. And methysergide is an infamous fibrosis producer. In fact, it can be fatal in extreme cases. So it was, from a historical standpoint, always a bit frustrating because like methysergide is really quite useful in terms of migraine prophylaxis, but the adversities of it are so substantial that it changes the risk-benefit analysis considerably. Okay, I'll stop.
But I think that's a great transition to this next slide where we're talking about migraines. And so serotonin has been a target for migraine treatment. So it just figured this would be a nice place to kind of introduce essentially the disease state. So this affects roughly 10 to 20% of the population. But the way a migraine presents is very different depending on the individual. So it can be with or without an aura. There can be a prolonged aura, an acute onset aura, a premonitory aura, and again, other things that kind of that are going to are kind of comorbid with this is photophobia, hyperacusis, polyuria, diarrhea, disturbance of mood or appetite. When people think of migraines, I think they often think of it's just kind of an extreme form of a headache. But I like this figure down here because it shows a very clear contrast as to how migraines are different or present different than headaches. So headaches are often not localized, and migraines are often localized. Migraines are going to do things like affect your vision and increase light sensitivity, which headaches generally will not. And then you might have a heightened sense of smell, and there's really no relief from painkillers. And so that's why developing another set of pharmacological therapies that can possibly treat it are so important. Can create nausea and vomiting, can last hours or days. And for an individual who has family members who have migraines, and I'm guessing multiple of you know this as well, is that migraines can be severely debilitating to the individual that are suffering from them, where they are, essentially rendered non-functional and are kind of just waiting for that period of that aura and that pain to essentially just pass. It can be so extremely painful for the individual. Essentially, how does serotonin kind of tie into the story of the migraine? So there are a couple of different pieces of evidence kind of that have shown this overlapping role of 5-HT or serotonin with the migraine. So plasma platelet concentrations of 5-HT vary with the different phases of the migraine attack. It's interesting to know that urinary concentrations of serotonin and metabolites are elevated during most migraine attacks. Oops. And also that migraines can be precipitated by agents that release 5-HT from intracellular storage sites. So essentially you can induce a migraine if you cause release of these. And so I like this figure here just because it essentially kind of showed that relationship possibly with migraine and the roles of vasoconstriction on the downstream effects and inflammation that may lead to a possible migraine attack. So again, you've got vasoconstriction that's occurring, inhibition of peptide release, and inhibition of the trigeminal activation that is occurring with these ergot alkaloids that we'll be talking about, and some of the other drugs that are utilized to essentially mitigate migraine, mitigate the effects of migraine. So we'll look at that kind of here in a second in terms of possible therapeutics. So treatment, again, that's kind of, I guess, a nice transition. So the triptans are, again, indole derivatives. We can kind of see that laundry list of the generic names of them here. They're very functional in decreasing things like nausea and vomiting, but they interact potently with the subtypes, serotonin receptor subtypes that we see here, the 5-HTB receptors. I included this table here. This is not something you'll necessarily need to memorize, but it does give you kind of a nice general understanding of what the dosages of each one of these drugs look like, as well as what the maximum dose would be. Kind of the mechanism of action is that they may cause constriction of these intracranial blood vessels and then closing the shunts and restoring blood flow to the brain. One of the more popular, I guess, drugs that are used, sumatriptan, is essentially administered via auto-injector. The oral administration can also be another route. And you see a peak plasma generation within 1 to 2 minutes, and also a nasal spray can also be administered with an onset of action for 15 minutes. And so here you can kind of see that mechanism of action of sumatriptan, where you have the drug binding to those 5-HT1BD receptors, inhibiting neurotransmitter release, and leading to this essential return to normal blood vessel dilation. So this is effective in acute treatment of migraine. However, it's probably, there are other therapies that could be used for maybe longer term chronic migraine sufferers. So another, I guess, serotonergic kind of a serotonergic target would be these ergot alkaloids that Keith has mentioned a few times. And so these ergot alkaloids, in terms of kind of the historical reference of them, they were first kind of characterized and found as a product of fungus. So here you can see the ergot on rye. They act as partial agonists, antagonists of 5-HT, dopamine, and the adrenergic receptors. LSD essentially falls within this category, and then essentially interacts with 5-HT receptors and is obviously a potent hallucinogen. And also it's been kind of characterized that the action of psilocybin, the active component in mushrooms, hallucinogenic mushrooms, is blocked by the pretreatment with this 5-HT2AC agonist. I included the picture of the ergot on the rye. Again, this is kind of how it would naturally be found. And then I also included a picture here of the Salem witch trial, because I think there's actually been some historical research and studies done that some of the symptoms and presentations of the women who maybe were identified and underwent persecution during the Salem witch trial may have actually consumed ergot on rye, which had led to these hallucinogenic, visions, and thus had maybe led the individuals around them to believe that they were witches. And so I'm going to pause here because I see Keith and I feel like he's got some good additions here.
Just to add in there, to expand it just a little bit,
Yeah.
also some evidence from Northern Europe in sort of related outbreaks of ergotism and witchcraft and so on, which are similar to the Salem situation in the United States. So that's a real interesting thing there for sure. And then just a little point about LSD. LSD is what we commonly refer to as a semi-synthetic. It's not actually found in ergot itself, but the precursors to it are, and then they can be converted to LSD. So yeah, this is a very, very fascinating area. As far as Montana is concerned, once in a great while, you'll see an ergot outbreak in Montana. Montana is so dry that you don't usually see it here, but in some really wet years, sometimes you'll get this fungal contamination up on highline parts of the state. But that's pretty rare in Montana. It's mostly sort of the Northeast United States, like Salem, Massachusetts. Thanks.
Yeah. And so this will probably be topic that we'll revisit because we have psychostimulants coming up here a little later on in the semester. So we'll probably do kind of a more expansive discussion of some of these compounds that we're just mentioning very briefly here. Again, we're kind of, I guess, going at it from more of their target receptors and not so much kind of them as categories of drugs per se. So in terms of the uses, the clinical uses of these ergots, alkaloids, you can see at the 5-HT1B, they are likely to mediate their acute anti-migraine effects. Their ergot preparations should be administered as soon as possible as the migraine onsets. And mirthosegic methyl oh my goodness, sorry, methyl thursergide, which Keith mentioned before, is used as a prophylactic for migraines. And so I just kind of included this table here that shows preventative treatments for cluster headaches and made sure that I kind of highlighted that particular one here. So you can kind of do a little bit of compare and contrast between some of the other drugs that are prescribed for this purpose. It's probably worth also recognizing that melatonin falls within this category as well, but kind of falls outside of the character structural that we're talking about here at this point. So other possible therapeutic targets of serotonin and serotonin kind of receptors or transporters. And so here you can see a list of kind of partial agonists for serotonin receptors. We kind of talked about those. If we go back several slides, you can see kind of those lists of receptor subtypes and then some of those agonists that are mentioned here. So if we go forward, again, it's just kind of a nice way to tie together those two slides if you need to refer to one. Partial agonists are generally used for the treatment of anxiety. The other way in which the serotonergic system is stimulated is through the use of things like SSRIs that block the uptake and prolong the dwell time of serotonin in the synapse and allow for longer activation of the receptors. And so you can kind of see the laundry list of the generic names of some SSRIs. I've included the table here so you can kind of compare and contrast both the generic name as well as the trade name for some of these. Um, sorry, somebody popped up a question. So some of these SSRIs again have different trade names. Again, probably the more popular one that we've heard about a ton is obviously Prozac, but many of these are commonly being prescribed now, but used for just treatment for depression, OCD, bulimia, and panic. In terms of partial agonists or SSRIs, Serotonin is approved for treatment of depression as well. So the question that popped up, and I might refer to Keith on this one just because he's probably very aware of kind of the characterization of this. So this chart said cluster headaches. Are those different than migraines in terms of characterization? So this chart here is essentially utilizing this for cluster headaches. But how would you differentiate between cluster headaches and migraines? Because I guess that previous slide kind of pulled those two things apart as migraines and headaches being different.
Yeah, I'll just jump in just very quickly on that one. They are different, and if you look at the international classification of headaches, they're separate categories. For our purposes, though, it's probably not a bad idea, at least to start, to say that they're certainly similar to each other in the sense of being extremely severe types of headache that are really, and Katie was alluding to this earlier, with migraine, for example, it's more than a headache. It's like a systemic thing. The individual is affected throughout the body, including especially the gastrointestinal tract. So yes, cluster and migraine are somewhat similar, but nevertheless distinctly different types of headache.
Mm-hmm. And so as we're talking about the therapies that are utilized for serotonin and target the serotonin system, it's worth recognizing that there are adverse effects that can occur when you're prescribing these either partial agonists or transporter blockers that are going to lead to alterations in the signaling of the serotonergic system. And so kind of the generalized effects of adverse actions is called the serotonergic system. This is essentially a constellation of symptoms that's sometimes observed in the patient starting a new or increased in antidepressant therapy or combining SSRI with a norepinephrine uptake inhibitor or triptan. They include this whole variety of possible symptoms that you see here. So they could be restlessness, confusion, shivering, tachycardia. You can see down here in the this table the clinical presentations of serotonergic system, and you can see how it affects not just central nervous system function, things like altered mental state, but you're also seeing neuromuscular abnormalities that can arise, as well as other serious complications as well. I mean, it ranges anywhere from renal failure to seizures as well as death. And so the prescription of the serotonergic targets are important in terms of recognizing any of these signs that might develop as the serotonergic system maybe isn't being altered at the kind of the correct relative level. And so, sorry, I kept getting distracted because there was a follow-up question for what we were just discussing. So for these medications, would they be treated the same for preventative? So if you're dealing with a migraine, or if you're dealing with a cluster headache, would they be treated at the same preventatively? And I'm guessing the answer to that will probably be there might be some overlap in terms of the preventative treatment, but I think it probably depends so much as to the origin and what the causative factor is for the headache or for the migraine, if there is a specific trigger that might be treating it. And so I guess it's very individualistic for that person as to what's going to be the best preventative treatment for care. And again, Keith, if you want to jump in here, Would cluster headaches and the preventative treatment for cluster headaches and migraines overlap?
Just to reiterate what you said there about, tremendous differential aspects from one individual to another, and the number of different triggers and factors and so on is just sort of mind-boggling, and it's one of the things that held up the field for quite a long time. The development of sumatriptan about 3 decades ago was a true revolutionary event in the history of anti-migraine drugs, and somewhere in the range of about 60 to 70% of acute migraine sufferers will get some relief from sumatriptan or the other triptans. Um, but the whole realm of migraine prophylaxis lagged far behind that, and because the triptans pretty much only interrupt acute headache, and the development of appropriate and reasonably safe prophylactics is taken forever. Just within the last year or two, there have been some developments along those lines. And when we talk about migraine later in the course, we'll talk about those rather unique drugs that are now targeted for chronic prophylactic treatment of migraine. So I know time's getting short here. I'll stop with that. And we will be back to migraine later for sure.
Okay. Um, and Maddie just kind of also mentioned that propranolol can also be prescribed to prevent migraines as well. So that's, I think, another like great kind of addition to this conversation. Obviously we're kind of focusing on the role of the serotonergic system in migraines, just because that's the focus of this particular lecture. But I think when we do get to that, the part of the class when we're talking about migraines, I think we'll see, since it is such a complex, I hate to say disease state, but since it's such a complex disease, that it just, I think that there are a lot of different directions at which you can kind of alleviate that issue. So it's interesting again to note that Maddie was throwing out that propranolol. Again, we have about 3 minutes left. The last thing I kind of have on my slide deck here today is our concept check. But before I send us off into that, I just want to again, I know Keith, I'm kind of leaning you hard on this lecture, but I just want to make sure that there's nothing that kind of gets overlooked. And if there's anything else that you'd like to add before I start that concept check, just because that'll probably be the last thing that we do for the day. So essentially, this is kind of my last, I guess, informative slide for the slide deck. So if there's anything else that you would like to add to this discussion, please feel free to take the time to do so.
No, just one quick note. That was a real good point about propranolol. And, in looking at the types of migraine prophylactics that we had in recent decades before just the last few years, propranolol is certainly one of those. Unfortunately, whether you're talking about propranolol or a calcium channel antagonist or whatever has been used for prophylactic migraine treatment up until very recently, not a large percentage of the population was treated well with any one of those drugs. And so it was always a bit of a roll of the dice in terms of knowing which particular prophylactic was going to be potentially useful for a given individual. So the propranolol is certainly one of the better of those. And I'm going to stop and let you finish up now.
Okay. Okay, so our last concept check question. Again, I think this might be not beating a dead horse, but we've definitely had some discussion about this. But again, looking at it from a kind of case study perspective. So a 40-year-old woman presents for evaluation of her chronic migraine headache. She reports that approximately once a month she has extreme unilateral headache associated with nausea and extreme photophobia. The headache will last for a full day if not treated. She has success in reducing severity of headache with an opioid pain medications, but usually she's too nauseous to take them. When she is able to tolerate them, she will have to sleep for several hours afterwards. She's missing about a day of work a month because of the headaches. She has no other significant medical history and takes no medications on a regular basis. Her examination today is normal. We decided to prescribe sumatriptan for her to try with her next migraine headache. So what is the receptor site of action and what is the mechanism of action? So kind of pulling this back into kind of the pharmacology and focusing in on kind of the receptor interaction. So if you want to just go ahead and kind of go back a few slides in the slide deck and kind of check out these answers, and go ahead, feel free to private message me your answer once you've kind of come up with it. Hopefully it doesn't take you too long. I feel like I've ran out of time. Okay. So yeah, I just don't want to take up individuals' time because I know it's important that we end on time. So it's officially 1:50. I'm just going to leave this up here. I've posted this case study as well as the answer to that on the next slide. That's what's uploaded to Moodle. So again, if you don't have time to look this up, again, it's worth kind of just revisiting and thinking about this more from the case study perspective. If you have any questions or concerns, feel free to reach out to Keith or myself about any of this material. Tomorrow we'll be kind of continuing our conversation on histamine, as well as hopefully beginning the endocannabinoid section. All of these neuromodulators, super interesting, super exciting, and obviously we're seeing how essentially expansive they are in terms of the types of diseases that they affect within the human body. Keith and I did quickly discuss the extra credit. Ultimately, we talked about how, for the most part, the grades are still looking pretty good. If there ends up being some type of situation that I guess might promote general welfare, I guess, Keith, you might be able to describe this better than I'm coming out with right now in terms of kind of our advantage on our perspective on extra credit.
Well, just in the past, we've at times given extra credit for situations in which something like a student group has a fundraiser or something like that, and participation by students in that would give us an opportunity to assign some extra credit points for that.
Okay, so I guess TBA. So, okay, I guess if no one has any other questions, I'll officially let you go for the day. And like I said, feel free to reach out if you have any concerns. Thanks so much, everyone. Have a wonderful day.